Hello to everyone, I'm Dr. Giacomo from Italy, and in this lecture that I prepare for Guided Education is aiming to describe an innovative prosthetic approach on implant support rehabilitations. This technique is finalized to reduce the incidence of chip fracture and at the same time to simplify the management of biomechanical complications. This approach is based on the adhesive combination of zirconia framework with monolithic lithium disilicate restoration. We start speaking about zirconia. Zirconia is a material that has really revolutionized the traditional prosthetic approaches in the last 10 years. In fact, we can take advantage from this material from several points of view, like the biocompatibility, low plaque adhesion, flexural strength, and aesthetics. In this case, for example, we can see critical clinical situations when we have continuous teeth on the right side and adjacent implants on the left side. So we know how this is one of the most critical situations that we can have in our clinical practice. But anyway, with zirconia abutment, it's possible to obtain a perfect soft tissues integration. And in fact, it's really difficult to find difference between the soft tissues integrations around the teeth and around the implants. And it's very difficult to find difference from health point of view, color point of view, and also texture point of view. With this option, so we can really idealize the soft tissues integration, and at the same time we can also simplify some clinical procedure, like for example the cementation, where we know how it represents really a critical aspect, because in particular in implant support rehabilitation is very important to be sure to remove completely the excess of cement. And if we have a prosthetic margin more commonly, like juxtagingival or extragingival, it's possible to be sure to remove perfectly all the excess of cement. I want to show you the finalization of this case after 1 year from the delivery. We can see the perfect soft tissues integration, good dental composition, and also after 7 years we can see how we have a stable result. Probably we had a slight recession on the implants, on the buccal aspects, but it doesn't represent any type of complication because with the white color of the zirconia it's impossible to compromise the aesthetic outcome. From the clinical data point of view, we know how today we don't have a long-term clinical study. We know how at 5 years the success rate of zirconia abutment and titanium abutment can be considered similar. And in the same time, from in vitro study, we know how it's really important to consider the type of the connection. Because in case of zirconia abutment, we can have zirconia abutment in an internal connection with metal component, we can have external connection, or we can have internal connection in a full zirconia. And from this point of view, the last option, so the full zirconia internal connection abutment, are absolutely the weakest from the biomechanical point of view. I want to show you this my experience that is not to be published, but probably it will be published in the next year, where I assessed 541 zirconia abutment. And I analyzed the survival rate in relation to the type of the connection. And I placed 233 zirconia abutment with internal connection and metal component, 198 external connection zirconia abutment, and 110 zirconia abutment with internal connection in full zirconia. And I observed this fracture, 0 in case of internal abutment with metal component, 1 for external connection, and 6 in case of full zirconia connection. And it means that this result is absolutely linear, it's clear like the in vitro study that we have. Because in case of full zirconia connection, the critical aspect is about the thickness of the internal walls inside the implants. And so it means that in case of a critical situation from a biomechanical point of view, like patient with a severe parafunctional habit or like periodontal patient, it's better to use to choose for an implant with internal connection and metal component in order to avoid to have complication with the abutment, with the stability of the abutment. The second option that we can have with zirconia in implant support rehabilitation, it's about the framework, zirconia framework, to treat full arch or partial rehabilitation. And from the clinical data, we know how it's really difficult to find fracture of the framework. The problem with this approach is directly correlated to the layering approach. So in fact, the most common biomechanical complication is the chipping of the feldspathic material that is layered on the top. And from this point of view, from the clinical data, we know how the incidence of chipping range from the 6 to 36%, with a follow-up period that it ranges from 3 to 10 years. So it's really an important variability. And the reason is that in order to avoid the risk of chipping, it's really important to take in consideration many parameters, many elements, like the framework design, like the layered porcelain thickness, like the properties of the feldspathic material, and at the same time the cooling down thermal cycles, like all the steps in the lab from the technical point of view. Today, in fact, we know how, in order to reduce the incidence of chip-off fracture, it's really important to perform the framework with the anatomical design in order to have a good support, in order to have protrusion that can support a uniform thickness of ceramics on the top. Like in this case, how we can see from the pics, where we maintain a really important protrusion on the axial walls in order to maintain a uniform thickness. And this option is absolutely important not only in case of teeth support rehabilitation, but also in case of implant support rehabilitations, where we know how we don't have any type of mechanoreceptor from the periodontal ligament, and so the system from a biomechanical point of view is more critical. In fact, we know from the clinical data how, also in case of traditional approaches like porcelain fused to metal, the incidence of chipping is absolutely higher in case of implant support rehabilitation than in case of teeth support rehabilitations. And this topic becomes really important in this type of treatment, where we have full mouth rehabilitation, and so where we don't have any type of mechanoreceptor. I want to show you this my case treated in 2006, one of my first cases with this approach with layered zirconia framework in a full mouth rehabilitation. And this is the pics after the delivery, and this is the image after 7 years. It seems to be good, but if I show you in a high magnification, it's clear to observe the number of fractures that I observe, a lot of fractures. And I try to manage this fracture with composite, with direct restoration, but without any predictable result. Because on the zirconia it's impossible to have adhesion, it's impossible to have a good bonding with the composite. And so it's normal, it's impossible to don't have a predictable result. So it's impossible to manage with reliability this type of complications. So in order to reduce the incidence of chip-off fracture, and at the same time in order to simplify the treatment, the management of biomechanical complication, we need a new solution. And this new solution can be represented by a new approach based on the adhesive combination of zirconia framework with monolithic lithium disilicate restorations. And this technique, it will be described on International Journal of Aesthetic Dentistry in December 2014 issue. This approach can be used in case of single crowns, where we can combine a zirconia abutment with a monolithic single crown. Can be used in case of partial rehabilitation, like in this case where we have a framework in the upper jaw, in the upper maxilla, from lateral incisor that is being treated by 4 monolithic crowns, but absolutely can be used in case of full arch, where really when we have biomechanical complication is really dramatic, it's really difficult to manage it from a clinical and also a technical point of view. This approach is based on 3 topics. The first one is the framework design. The second one is the monolithic lithium disilicate manufacturing, and the third one is the pairing technique. About the framework design, it's really important to have a prosthetic design of the framework in order to have a vertical path, in order to cement vertically the restoration on the top of the framework, because the lithium disilicate is a strong material, 400 megapascal of flexural strength. And it means that he doesn't need a real support, a strong support by the framework. So prosthetic design, no an anatomical design like in case of a traditional layered approach in case of zirconia or metal framework. In fact, this is, for example, the typical framework design that we have in case of layered approach. An anatomical design with protrusion in order to maintain a uniform thickness of ceramics on the top. While with this new innovative approach, the design is completely different. We have a prosthetic design, and we can see from the slide how we don't have the protrusion. It doesn't matter to obtain a uniform thickness on the top. And it's really clear if we observe this slide, where we assess the same framework from another point of view. We can see, in fact, in the case of a layered approach, we have an anatomical design and we maintain a uniform thickness of ceramic on the top. While in case of ligament silicate approach, we have a prosthetic design, no protrusion, no undercuts, in order to have a perfect vertical path of the restoration, that it will be cemented by an adhesive combination. Another topic is about the thickness, because in case of layer approach, we have to maintain a uniform thickness of about 2 millimeters, while in case of ligament silicate approach, we can maintain also bigger thickness, like 3 millimeter in occlusion. It's important to maintain at least 1.5 millimeters in occlusion and at least 0.8 millimeters on the axial walls. But an important topic is to consider the difference in flexural strength between the feldspathic porcelain that we use in case of layer approach and the monolithic lithium silicate that we use in case of with the new approach. In fact, in case of feldspathic porcelain, we have simply 110 megapascal, while in case of lithium silicate, we have 400 megapascal, and absolutely is a strong material, stronger material respect to the feldspathic porcelain. And this is an important thing to consider in order to reduce the incidence of chipping. And now I want just to introduce a topic that we will discuss in the last part of my lecture. In fact, we imagine to have a chipping on this type of framework. It's clear that if we have a chipping in case of layer approach, normally we have a chipping with a zirconia exposure. It means that we don't have a big area to etch and where to create a good bonding for composite in order to have a predictable direct restoration for the fracture management. While if we have a chipping in case of monolithic lithium silicate approach, usually we have a cohesive chipping, so we don't have a zirconia exposure. And it means that we have a big area to etch, a big area where to create a good bonding between the composite that we generally use to treat and to manage the biomechanical complication. But we will discuss in deeper on this topic in the last part of my lecture. The second topic is concerning the lithium disilicate manufacturing. We know how the lithium disilicate can be produced with two technologies: press technologies or CAD/CAM technologies. Both techniques are reliable. To be honest, I prefer the press technology because with this approach we can fabricate crown, we can obtain bridge, fixed splinted crowns, 3-unit bridges, 4-unit bridges, and also 6-unit bridges. While in case of CAD/CAM technology, we can simply obtain single crowns or simply 3-unit bridges. And this is an important consideration to do when we have a big treatment, like for example, full arch. In this case, in fact, is more a flexible approach to use a press technology in order to have the possibility to manage the framework with crowns, single crowns, and also 3, 4, or 6-unit bridges. The use of monolithic lithium disilicate material, it was introduced by in vitro study in 2010 by Petra Guest, where she assessed the difference between monolithic lithium disilicate crown versus hand-layered zirconia crown. And this in vitro study shows how monolithic lithium disilicate material exists until 900 Newton, while the zirconia crown after 200 Newton manifested complication, fracture. And this result, it was also evaluated, it was also described in many clinical studies, like the mine that I published in International Journal of Peri-Restorative Dentistry in 2014, where I assessed 860 lithium disilicate restorations, places both in the anterior and the posterior segments. And my success rate that I observed was ranges from the 95% to 100%. And it's important to consider that in my study population, the 33% of the patient had parafunctional habits, severe parafunctional habits. And this is an important element to consider in order to speak about reliability of this approach. So this is the reason why we decide to use these materials, so the monolithic lithium disilicate, also in case of implant support rehabilitation, so in order to recreate the occlusion on the framework, on the zirconia framework. In the first my experience with this approach, I usually treat the zirconia framework with single crowns. But today, in order to simplify technical and clinical procedure, I prefer to treat the framework with bridges, usually 4 3-unit bridges. In this way, we can really simplify all the clinical and the technical procedures. It's really important to design, to fabricate the crowns or another type of monolithic lithium silicated restorations with a screw hole access. In this way, we have the possibility to reach, we have the screw during the application of the rehabilitation in the mouth in order to have perfectly a screw retainer rehabilitation and in order to maintain all the advantages that we have in case of screw retain based approach. Now I will show you our first case, a full mouth rehabilitation with this new innovative prosthetic approach on the upper and the lower jaw. And I want to show you how we manage the lower framework with the zirconia framework and the monolithic lithium disilicate obtained by press technology. And in particular, we have a 6-unit bridge in the anterior segment and 2 3-unit bridge in the posterior segments. And finally, we obtain a screw retainer rehabilitation because we can see how really we can easily reach the screw on the implants in order to have perfectly a screw retainer rehabilitation, maintaining all the advantages that we have with this approach, like for example, the possibility to remove it easily in case of biological complication. Now we can see the aesthetic outcome that we can achieve with this approach. Simply with the staining technique, we can see how really it's possible to obtain good characterization, both in the incisal portion than in the occlusal portion. And from the video also it's possible to see the type of occlusion that I obtain in my rehabilitation, anterior and lateral guidance, and it's also important to assess the natural appearance of this type of result. In particular, if we look at the face of the patient during the smiling and during the phonetics, good natural appearance that is not easy to understand, that is simply obtained by a staining approach without any type of layered material. A second option, it could be to create this type of approach but cement with an intraoral cementation. So to design the lithium silicate restoration without the screw hole access and cement them intraorally. To be honest, I not recommend this approach because I think that the advantage of the screw retainer rehabilitation is an important feature to maintain in our rehabilitations. And so I recommend this option only in case where we have an adverse implant angulation. For example, where we have the screw hole access in the buccal aspect of the anterior teeth, where it's unacceptable to maintain the screw hole anteriorly, because it can really compromise the aesthetic outcome. About the framework design, the framework fabrication, it's important to consider 3 aspects. The first one is the connector. So the height of the connector in order to give a good strength, a good support to the framework. Secondly, it's important to consider the height of the abutment in order to have the possibility to give to the crown or to the restoration a good retention to the framework through an adhesive cementation. And third is the space for the occlusal reconstruction, that must be at least 1.5 mm in occlusion. This is a parameter very important to consider, in particular in case of regular denture, where we don't have important vertical height to consider. This is, for example, a framework that in the posterior segment that I treat with a 1 3-unit bridge. And we can see that also with a small space, a poor vertical space, is possible to obtain a good result, obtaining a good aesthetics with a 1.5 mm in occlusion. In order to have a good natural appearance, it is absolutely important to use HT ingots, so high translucency ingots, because it's the only material that we can use with this approach, because if we use more opaque material, it's impossible to obtain a good natural appearance from a prosthetic and aesthetic point of view. In case of hybrid prosthesis, the situation is different because in this case we have important vertical height. And so in this way we can manage the space from the connectors, from the abutment height, and from the occlusal reconstruction differently. In this case, for example, I maintain a thickness in occlusion that is of about 3 or 4 millimeters, so really bigger than in case of traditional approach. And these represent really an important element, a strategic element to consider in order to manage the biomechanical complication, but we will discuss about this in the last part of my lecture. The third option that we have to consider in this treatment with this innovative approach is correlated to the pairing technique between the framework, so the zirconia, and between the lithium disilicate. And we have two options. The first one is an adhesive approach, an adhesive cementation, so through a resin cement. The second is the CAD-on technology, through a crystallization process. So I think that the adhesive approach is absolutely the more flexible in this clinical treatment because it's possible to use in all clinical situations from the single crown to the full arch. While CAD-on technology can be useful only in case of partial rehabilitation. For example, for single crown or for bridge, 3-unit bridge, for example, because it's really not recommended when we have to combine one framework with more lithium silicate restoration, like for example, one framework with 2 or 3 single crowns or bridges. So it's really recommended for partial rehabilitation and not for full arch, for example. In case of adhesive approach, of the adhesive cementation approach, is really important to treat the internal surface of lithium silicate restoration like in case of traditional prosthesis, so like in case of natural teeth support rehabilitation. So we have to clean the internal surface with alcohol, to etch the internal surface, to clean again, and then to finalize the treatment with the resin cement. It's really important to consider that we have an important distinction between the cementation of bridges and the cementation of single crowns, because the topic is that single crowns can have a slight rotation on the framework. So it's not so easy to cement them in the perfect position, maintaining the occlusion. So this is the reason why I love to perform bridges in the posterior segments, because in this case with bridge, like we can see in the movie, in the video, it's possible to have a perfect cementation because the bridge cannot rotate on the framework. And so in this way we can cement perfectly the bridge in the posterior segments. We clean the surface of the framework with orthophosphoric acid simply to clean without any etching approach, because we know that how on the zirconia it's not possible to etch the surface. We etch with the hydrofluoric acid the internal surface of lithium silicate, and then we cement with the dual cements the cementation on the top of the framework, without any risk to do a mistake about the position of the restoration on the framework, because with bridge it's impossible to have a rotation. It's important then to clean the excess of cement with scaler or with microblade in order to remove perfectly the cement from the edentulous area. While in case of single units, the situation is different because crowns can rotate on the framework for the problem with reason concerning the fit of this crown on the framework. So it's really important to have the possibility to recreate the position during the cementation. And so we can use or the articulator or we can use silicone index. We can see from the video like I cement the anterior teeth and then I put the model on the articulator in order to verify exactly the position of the crown. And only after this procedure I go with light curing in order to start the polymerization of the cement. In this way I'm sure about the perfect position of the crown on the framework. In fact, in my first experience with this approach, like we can see in this case, where I performed 14 single crowns on zirconia framework, the cementation was really difficult because it's really difficult to cement 14 crowns on the framework. And in fact, in this case, I used silicone index, a rigid index, in order to be sure to recreate perfectly the position of the crowns on the framework. This is the final outcome after the luting procedure, and this is the final result in the mouth of the patient 5 years after delivery. And we can see how we have achieved really a good result from an aesthetic point of view, and we can see the good characterization that we obtain simply with the staining approach, both in the incisal portion than in the cervical portion. And remember that for obtaining this type of result is possible only with HT ingots, so high translucency ingots. That are the only material that allow to us to obtain a good natural appearance only with the staining approach. Pay attention on this slide, because in this slide I have summarized about the topic of this technique, and in particular I compare exactly the layer approach with the monolithic approach. So first of all, we have just seen how an important difference is correlated to the flexural strength in occlusion, and we have 100 megapascal for the feldspathic material and 400 megapascal for the monolithic lithium silicate. And it means that in this way we can really reduce the incidence of cohesive chipping. Secondly, another important topic is correlated to the union that we can achieve between the porcelain and between the zirconia, because in fact we know how in case of layer zirconia the bond strength that we can have with the porcelain and the framework, it's about 10 megapascal. And remember that in case of PFM restoration, this value is superior to 27 megapascal. So we have an important difference between these two approaches, between layer zirconia and layer metal, so PFM restorations. While in case of lithium silicate approach, we can achieve a union with the framework of at least 25 megapascal in relation to the cement that we use. And so in this way we can really beef up our rehabilitation. We can really reduce also the incidence of adhesive chipping, so of the chipping with the zirconia exposure, because we can really beef up the strength between the zirconia and between the lithium disilicate. Actually, we don't have important clinical data about this approach. The only one that we have is by Alessandro Pozzi, a clinical study with the follow-up period range from 3 to 5 years, where he assessed 18 rehabilitations with a total number of 236 single units. And he observed only one chipping. So he had a success rate of 100%. So absolutely is a good result. But I know that in order to have a good support from the clinical data, we need more clinical studies with the longest follow-up period and a big number of clinical cases. So, in conclusion, about the advantages of this approach, we have just seen about the biomechanical advantages in terms of flexural strength, in terms of flexural strength in occlusion. But then the second topic, really important with this approach, is correlated to the possibility to manage perfectly the biomechanical complications. In fact, which type of biomechanical complication we can observe with this approach? We can observe a minor chipping without a zirconia exposure, or a major chipping with a zirconia exposure. And how we can treat them? In case of minor chipping, we can use the bonding, and so we can do direct restoration in composite in order to repair the fracture. So I want to show you my complication that I observe in my experience that it take in consideration about 41 rehabilitations. I want to show this case, for example. This is a fracture that I observed simply 1 week after the delivery. Probably is my mistake during the occlusal equilibration, and the patient came to my care with a fragment. And so I decided to treat this problem simply through the bonding. So I etch the surface in the mouth of the fractured crown, I etch the internal surface of the fragment, and then I bond the two components together with the resin cement. And this is the result that I obtained after 6 years, still in the mouth, in function, without any type of discoloration or complication. It means that the bonding is absolutely reliable with these two materials. That is the same material, lithium silicate. Another fracture in the upper, a premolar, a minor chipping on the premolar, and I treat it perfectly in the same way. So with the direct restoration, I etch the surface, I use a sealant, adhesive, and then composite. And this is the result after the procedure, and finally the result after 3 years. Also in this case, the restoration is still in the mouth and in function. And to convince you about the reliability of this approach, I want to show you this case. In my clinical case treated in 2005, two posterior crowns on this anterior teeth, this chromic abutment. I love to use posterior crown in the anterior segment in case of this chromic abutment because it's a good material and it allows to us to mask the discoloration and at the same time to maintain a good natural appearance. But this was a patient with severe perfectional habits, and in fact after 2 years the patient came to my care with this problem, a minor chipping on the incisal edge. So I had to replace again the restorations, and in order to give to the patient the possibility to have something of more reliable, I decided to use a monolithic lithium silicate. But in this case the problem is the dyschromy, the discoloration of the root. And so I'm forced to use more opaque ingots, and in this case simply with the staining approach is impossible to obtain a satisfactory result. And in fact the prosthetic outcome that I achieved, it wasn't satisfactory for me and for the patient also. So I had to remake the restoration again. And in the first time I thought to remove completely the crown and to redid again the new crown. But I thought that this is a crown that this was a crown that it was completely etchable, like the enamel. So I decided to prep the monolithic lithium silicate crown like in case of tooth. And so I prepared the crown to receive a veneers in more translucent material. And I cement the veneers on the top of the crown, like in case of traditional prosthesis, in case of aesthetic treatment. And the cementation also is really similar. The only difference is concerning the acid, because in this case I use hydrofluoric acid and not orthophosphoric acid. But the approach is the same. And this is the result that I obtained after 5 years. It's a good result in function without any type of complication from biological point of view. We can see how also in the palatal aspect we don't have any type of discoloration or infiltration, and it means that the bonding that we achieve between the lithium silicate through an adhesive cementation is absolutely reliable. In fact, we can see how after etch, this is how lithium silicate appears. The same image that we have when we etch the enamel. And also, if we look the lithium silicate after etch in a high magnification with a microscopy, we can see this type of image that is really very similar to the image that we have when we etch the enamel. In fact, in this slide we have the enamel after etch and the lithium silicate after etch. And we can see how, from a micromechanical point of view, the surface is really similar. So if adhesion is so reliable in case of enamel, of course, probably also with the lithium silicate, this approach is absolutely predictable in lots of clinical situations. And what about measured chipping? To be honest, in my experience, 41 rehabilitations with this approach, never I observe a measured chipping. Because always in this case I observe cohesive chipping without a zirconia exposure. And this is a really strategic point, because in this way I have always a big area to etch and where to create a bonding. But anyway, if I will have a measured chipping, I will have the opportunity to remove completely the fractured crown and to replace a new crown, because I have the possibility to cement on the top with the vertical path the new crown on the framework. And this is an important advantage in my opinion. I want to show you this case, a fracture after a road accident. Because remember that fracture can happen also for external trauma. And this is what I do. The patient was really worried about this because she thought that she has to replace, to redo completely the rehabilitation. But I treat in 10 minutes this situation with composite, with a direct restoration, because on lithium silicate we have the possibility to create a good bonding. And then after 5 months, this is the situation, still in the mouth, in a good condition. And now we decide to remake completely the new crowns, so we remove the lithium silicate crown, like in case of traditional approach, so we create sulcus, we remove the lithium silicate, we expose perfectly the zirconia, we take an impression, we give the impression to the dental technician in order to obtain 2 new crowns in monolithic material, lithium disilicate with HD ingots, and then this is the final outcome. So we have the possibility to repair perfectly the situation, and this is really an important topic to consider in our clinical practice, both for us and for the patient. And this is the final outcome after the cementation of the 2 new crowns. I want also to show you a small video about the technique. So like in case of traditional prosthesis, we remove the old crown, creating sulcus on the vestibular and palatal aspects. We remove completely the lithium disilicate material and we expose perfectly the zirconia. Remember that is a screw retain rehabilitation, so we have also the possibility to remove the rehabilitation, the arch from the mouth, and to do all this procedure in the lab. But I prefer to do this approach in the mouth because I simply need 2 appointments of 1 hour for each. So it's really easy for a dentist, this type of approach. So after to remove the lithium disilicate, we take the impression, and it's really easy to take this type of impression. It's really important to avoid to overheat the framework for the risk to create a fracture, to create complication inside the framework. And so it's important to work with a lot of water from the instrument. And the impression can be taken simply with silicone or with polyether. And remember, and I repeat, it's really easy, like impression, because we don't have any problem with the soft tissues. In this way, the technician can produce the 2 new crowns, and in this way, I have the possibility to cement the 2 new crowns in the mouth of the patient. In this part of the video, we can see the tray-in, and I cement the new crowns simultaneously in order to be sure about the position of the 2 new crowns. So I cement contemporarily the 2 crowns. After to evaluate the shape, the color, I want to be sure about the position, and then after that I check again the position with the occlusion, and finally I start with the light curing in order to start with the polymerization of the cement. Then we remove the excess of cement with the scaler, with the microblade in order to remove perfectly the excess of cement also in the area in border between the lithium disilicate and the feldspathic porcelain inside the sulcus. And then finally we have the possibility to repair perfectly this rehabilitation. In this phase, for example, we can see the excess of cement from the palatal, and this is the phase after this is the phase of the microblade where we remove perfectly the excess of cement from the sulcus, and then we can see exactly the final outcome after the polishing. And we can see how really it's possible to achieve good result, good prosthetic integration of this new crown, of these 2 new crowns. And now I want to invite you to imagine to solve this type of complication in case of a traditional approach. So in case of porcelain fused to metal or to zirconia, where additional baking is not recommended and where bonding procedures aren't reliable for the minimal ceramic thickness that we have on the top, for the metal that can compromise the aesthetic outcome. And so I want really that you pay attention to this aspect of this approach that, in my opinion, is really important. Because remember that to find the strongest solution in order to give to the patient a reliable result is good, but is not really convenient, because we need strong solution. But in the same time, we need the possibility, the opportunity to manage perfectly and with the reliability the biomechanical complication if they will happen. Unfortunately, we don't have the possibility to use this approach in all clinical situations, because from biomechanical reason, sometimes we are forced to use titanium framework. In particular, like in this case, where we have an all-on-4 approach and when we have an important distal cantilever on the right side. But anyway, we can treat this patient with the same approach, with a prosthetic design of the framework with titanium and not zirconia, and with monolithic lithium silicate restoration cement on the top. We can see, in fact, in this case, how we have a zirconia framework in the upper jaw and a titanium framework in the lower jaw. The only difference is correlated to the framework in relation to the necessity to put an opaque material on the top of the abutment in order to mask the discoloration. And in this case, I prefer to use an opaque material with for composite. And the second difference is correlated to the necessity to recreate the soft tissues, the pink tissues, with composite and not with layered ceramics, with feldspathic ceramics. And it means that we have the risk to have pigmentation after many years after the delivery, in particular in patients that are big smokers. But anyway, in this case, the patient isn't a smoker, and in fact, after 1 year, we have a perfect stability of the prosthetic and of the aesthetic outcome. This is the integration of microrehabilitation in the face of the patient and in the smile of the patient. And we can see how really it's possible to achieve a good aesthetic integration simply with a staining approach without any layered approach and any type of feldspathic material. I want to show you a small video about this patient concerning the delivery of the rehabilitation. We can see now the aesthetic integration, the good natural appearance of this type of prosthetic treatment, and it really is difficult to find that we don't have any type of feldspathic material layered on the top of the framework, but really we can see how, thanks to the HT ingots and the good staining approach, it's possible to achieve a good integration. And we have seen, in fact, in the video, the good natural appearance of the prosthetic outcome. So, in conclusion, I want that you pay attention on the typical question that our patient has before to start with a new treatment. And the question is, doctor, for how many years can you assure me this treatment? And really is a difficult answer for us, because we know how it's really difficult to find a good answer. It's difficult for us to give a number because all patients are different from biomechanical and biological point of view. But in this case, in implant-supported rehabilitations, for me, we have a solution. Because my answer is that for me, it's difficult to give to the patient a number. But anyway, don't worry. Don't worry, because we have really the possibility to manage perfectly the complication. And this represents really an important advantage, both for us and for the patient. Actually, this monolithic zirconia, it seems to be the go-to solution in the future. Yes, it's absolutely the strongest option that we can have in our clinical practice. But with the monolithic zirconia, we don't have the possibility to manage it in case of biomechanical complication, because we don't have the adhesion, we don't have the bonding, and we don't have the possibility to manage easily in the mouth, because it's really an hard material. So remember, strong material, but in the same time the possibility to manage it perfectly in the mouth in case of biomechanical complication. Thank you very much for your kind attention.
For more education programs, visit the Guide Institute at www.guidedental.com.